I believe Senator Mitchell.
Just a quick question, sir, if I may. And I'm not sure if I should direct this to the department or LAO, but when I look at the LAO report and in listening to some of your questions, Mr. Chair, the LAO report, page 2, that talks about some of the federal requirements that may be waived, it occurred to me, what do other states do in this circumstance as we try to figure out how do we create this balance and to tier or not to tier? Sure. What do other states do who are having to abide by these same federal requirements, particularly the no hold harmless requirement that cannot be waived?
So other states are grappling with the same question now. No other state has changed their tax as of yet. There aren't that many states that, so unlike with our like hospitals and nursing facilities where lots of states have those taxes, I think there's only a handful of states that have managed care taxes. You know, and they have not yet, I haven't even actually heard of a proposal from another state yet as to what their structure might be.
And do those other states have the same sunset date? So we're kind of operating under two timelines, our sunset date for the existing MCO tax as well as the federal hammer. So
the federal government had indicated in their guidance that all states needed to address this issue by the end of their next legislative session when they announced that last year. So that was why. So it just happened to be timed the same as our sunset date. So other states are in the same time frame as us. You know, I don't know why they have not yet come out as far as I know in with proposals, but they have not yet as far as I'm aware.
Thank you.
Sure.
So, yes, Senator Nielsen.
If I may quickly follow up on that then. So our MCO tax tracks with others, so it's not up until next year. So we don't have to embrace an MCO tax this year. We could wait till next year, is that correct? There's no sort of Damocles over our heads related to the MCO tax. It extends into next year.
We have the MCO in the current year. So the budget that just started yesterday does have the MCO tax in its current form. Mm-hmm. It expires at the end of the current year.
Okay.
Current fiscal year, so next year, June 30th, so July 1st, if we don't re-up it, there's no money.
We have the whole.
And according to the federal, we have to have done it before we adjourn also, sign a die.
Right, so by next year essentially too as well, yes.
Thank you.
So I believe Senator Morlock asked a question with regard to the different types of plans, and I think you had mentioned for me to respond. Oh.
I just thought you might be familiar with since you're in the industry, what's been happening. So
well, what I can do is I can just kind of give an overall. So managed healthcare plans in the state of California are licensed under the Department of Managed Healthcare. Private health plans are licensed under CDI, which is the insurance commissioner. And then not all plans choose to see Medi-Cal, but the plans that choose to see Medi-Cal patients have to go through their department. So it's difficult to get information from what a private plan does through CDI or a private plan that does through the Department of Managed Healthcare because they don't do business through this particular entity. So where I think the most difficult, and you made a comment, and I totally agree about hospitals that have thin margins, but I think what we need to distinguish is the different types of hospitals, but more importantly, the different types of healthcare facilities that have different margins. So the facilities that have the absolute most difficult time, that has the absolute thinnest margins, are the ones who usually see predominantly Medi-Cal patients, as opposed to an entity or a facility that takes, open market, have much higher profits, who choose not to see Medi-Cal. So when you have an entity that's like a federally qualified health center, a health system that's 98 to 99% Medi-Cal population, any amount of less money, it's going to impact their margins significantly more than an entity that has higher margins. I mean, so
you're saying that it's a good idea if you're a medical doctor not to do Medi-Cal?
I'm not saying that. I am definitely not saying that.
I'm sorry, I misunderstood. I'm sorry.
What I'm saying is if you choose to see Medi-Cal, your returns are a lot less, your margins are a lot lower, and you have to make it up in volume. So I am encouraging every provider to see Medi-Cal patients. But I also believe that if they're choosing to do that, that we should make sure that they, at least at a minimum, maintain their current rates and not increase their current rates. Because those are the providers, whether it's hospitals, federally qualified health centers, providers, individuals that give services, durable goods, they're getting probably the lowest amount of return for the service that they're providing. I don't know if that kind of helps.
No, I think you answered my question, but I'll leave it at that.
Okay, all right. No other questions from any of the members? Anyway, I want to thank you for the presentation. I appreciate it very much. We'll move on to the next section. That's identified program shortfalls, item number 1. We're going to have all the presenters come up here, Medi-Cal program, MCO, and provider rates. Felix Su, Senior Financial and Policy Analyst, Health and Human Services, Legislative Analyst's Office. Item number 2, Developmental Disability Services Rates, Sean Martin, Principal Analyst, Human and Health Services, Legislative Analyst's Office. Item number 3, In-Home Supportive Services, Gina Bella Navera, Managing Principal Analyst, Health and Human Service, Legislative Analyst's Office. And if the members don't mind, I'd like to have everyone give their present. Did I miss somebody? What's
Jason Sisney from the LA.
Oh, okay.
For here too.
Sorry. Jason Sisney, Chief Deputy Legislative Analyst, State and Local Finance Analyst, Legislative Analyst's Office. And I'd like to ask if the members don't mind, all the presentations first, and then we can open up to questions.
Thank you, Mr. Chair, Senators. Felix Su with the Legislative Analyst's Office. So I will be kicking off our panel's testimony by providing background and context for the Medi-Cal portion of today's hearing. So my remarks will cover both the MCO tax overview and issues related to Medi-Cal provider rates. And I'll be working off of the 3 sets of handouts that are circulating right now that I think were included in your packets. And just one note is that we compiled the handouts in advance of receiving the agenda for the hearing, so they're a little bit out of sync with respect to the ordering of the agenda. So to accommodate that, I'll have to sort of jump between 2 of the handouts. So just bear with me when I make the switch. So I'll be starting with the handout titled Overview of MCO Tax, Selected Other Tax Increase Options, and IHSS Issues. So I realized that the department and the administration covered a lot of the ground that I was going to in the opening panel, and they did a very good job of that. So in the interest of leaving as much time as possible for your questions, with your agreement and permission, I thought we could just sort of jump ahead to some of our more substantive sort of takeaways from the governor's proposal on the MCO tax. Of course, you can always circle back to any sort of previous part of the handout and ask us questions about more of the nuts and bolts of how the tax works and how it would sort of comply with federal requirements. But I thought it would be useful to jump ahead to page 8 of the handout, which is sort of a hard visual graphic to get your head around at first, but I think if you give it some time, it gives a nice sense of visually what the distributional considerations are in considering the governor's proposal. So one thing that I want to clarify as you look at that graphic is that as an artifact, really, of federal guidelines for setting Medicaid managed care rates, the state is actually able to continue to build in the cost of the current MCO tax or even a restructured MCO tax into Medi-Cal managed care. And in that way, it can actually, in effect, hold the MCOs harmless for the tax they pay on Medi-Cal. This is despite the fact that under federal guidelines, formally, you are not supposed to be holding taxpayers harmless for the tax that they pay. So that's one important nuance. And this might be helpful with a theoretical example. If ABC Health Plan enrolls 2 million lives, half of them being Medi-Cal covered and half of them being in the commercial line of business, then under the governor's proposal, ABC Health Plan would be held harmless for the tax that it pays on the Medi-Cal enrollment, but not for the tax it pays on the remaining commercial enrollment. So technically, if you are a plan that does only Medi-Cal, then you are neither ahead nor behind as a result of paying the tax because you get back what you owe. And what we do in the graphic on page 8 is essentially we array the plans from smallest to largest, and each column here represents a different plan, and we don't identify the plans by name, but this is based off of enrollment data from the Department of Managed Healthcare's website. And as you can see in the legend, the dark part of each column signifies how much commercial coverage or non-Medi-Cal business each plan does, while the light colored portion signifies how much Medi-Cal coverage they provide. And plans that are purely light shaded would effectively see a tax rate of 0 at the end of the day, whereas plans with a purely dark shaded or a mostly dark shaded column would owe a lot of tax that they would not be able to be held harmless for. And this is why we think in economic terms, the proposal really resembles an actual tax on commercial coverage, because that's what's really going to be costing you if you're a plan that has to pay the tax under the way the governor's proposed it. And as was pointed out in the discussion in the previous panel, we think it's likely that eventually the industry would pass on some of this net cost to consumers of commercial coverage, including, for instance, CalPERS, which the state purchases healthcare for employees and retirees. Now, all that being said, we do think the governor's proposal is worth considering, strongly worth considering, given the important funding goals that it's meant to fulfill. We just have a couple of comments that we outline on page 9 of the handout, which is that as proposed, the structure the governor is offering is an enrollment-based tax. And yet the cost that it's meant to sort of stabilize and backfill would grow at a rate that's faster than the tax base. This is because enrollment would grow with the general population, whereas costs in the Medi-Cal program would grow with healthcare inflation, which would probably outstrip the rate of population growth. We make a similar consideration for wage and caseload growth in the IHSS program. Therefore, because the tax has to meet federal requirements in order to be permissible, we could be in a situation, if you authorize something like the governor's proposal, in which the Department of Health Care Services has to each year come back to the federal government to make sure it signs off on the recalibrated tax structure. Now, to potentially address this issue, you might consider an option where you explore a tax structure, maybe it's tiered, maybe it's not. You try to set the rates to sort of meet the funding goals that you are prioritizing, whether it's general fund offset or IHSS restorations or other areas. But you do so in a way that taxes revenues rather than enrollment, because the revenue tax base would grow at a rate that's more in step with the costs that are being funded by the current MCO tax. And I just wanted to close with what I think are the two most key takeaways about thinking about the MCO tax during this special session. One is that, again, to recap all of the great discussion we had in the first panel, to comply with the federal requirements, you basically, at the end of the day, have to tax commercial coverage at some rate. And two, the governor has proposed that the tax be used to offset general fund costs and fund other purposes in IHSS. The tax will not be used to provide a net benefit for Medi-Cal managed care plans that are paying the tax. So this translates ultimately into some plans losing out financially, either under the governor's proposal or even under an alternative structure that purports to achieve the same funding goals. So I'll close with an example. If out of concern for the mid-sized plans that don't do much Medi-Cal that would be disproportionately hit in terms of financial impact under the proposal, the legislature were to consider a flatter tax structure, then this would mitigate the impact on the mid-sized plans, but it would come at an inherent trade-off, which is that one, the amount of federal funds that would be leveraged by the tax would be less, and two, the net liability or cost to the industry would go up, especially for some of the largest health plans in the state that serve the most members. With that, I will shift gears and handouts to Medi-Cal payment issues. So we were asked by the committee to provide an overview of past budget reductions that are still in place in the Medi-Cal program, as well as proposals to restore those reductions and provide further increases to rates. So the 2011-12 budget authorized across-the-board 10% rate reductions in fee-for-service and in managed care. These are commonly known as the AB 97 rate cuts. Now, the cuts were enjoined by the district court through June of 2013. Once the injunction was lifted, the state had the authority to both proceed with the rate cuts and to also collect the reduction amounts that were applied to the period in which the injunction was in place. This is commonly known as the recoupment or clawback process for AB 97. So on page 2 of this handout, we point out that AB 97 allows the administration to exempt certain providers from both the ongoing costs of the cuts as well as the clawbacks in order to comply with federal access requirements in Medicaid. And the administration has granted exemptions, either one or both types of exemptions for some providers in recognition of these access concerns. For the 2015-16 budget, the state eliminated the ongoing rate cuts for dental providers at an estimated cost to the state of $30 million annually. Finally, on pages 3 and 4 of the handout, we describe SB 243, which was introduced this session, which would restore the remaining AB 97 reductions and also require further rate increases above the baseline of restorations. For example, it would raise inpatient rates for hospital services, which are actually not subject to the AB 97 reductions. And it would also raise fee-for-service rates to Medicare or Medicare comparable levels and require a commensurate increase in Medi-Cal managed care. The Senate Appropriations Committee has estimated that the annual cost of this proposal in terms of general fund would be $6.6 billion annually. Thank you.
Sean Martin with the Legislative Analyst's Office. I will be talking about the Department of Developmental Services. You should have a handout. It's the overview of developmental services issues, and I'll be speaking from that. If you turn to page 1, there's an overview of the presentation. First, I'm going to provide background on the Department of Developmental Services programs. Then I will discuss the rate structure for the regional center system. I'll go over major DDS budget solutions that are affecting the community services program from 2003-2004 through 2015-2016. And I'm going to focus on vendor rates and regional center operations funding formula. After that, we'll go over issues that may affect rates in the near future, specifically new federal home and community-based services regulations that the federal government has enacted, and the closure plans for developmental centers. And then finally, I'll discuss the Developmental Services Task Force, which is examining service rates and regional center operations formula, and then just briefly go over recent budget actions. So if you'll turn to page 2, I'm going to focus on the Community Services Program. Community services are provided through 21 nonprofit regional centers that are located throughout the states. They assess eligibility, and they also provide caseworkers for people who are deemed eligible for regional center services. The regional centers vary in size. Redwood Coast has about 3,300 consumers, whereas Inland Regional Center has 29,000 consumers. And the department provides regional centers with an operations budget to conduct its business. The regional centers purchase more than 100 services from vendors on behalf of regional center consumers. These include housing, day programs, transportation, and support services. The regional centers are the payer of last resort. They can only purchase services for an individual if so-called generic services, such as other state-administered health and human services programs for low-income persons, or services that are generally provided to all citizens at the local level by counties, cities, school districts, or other agencies are not available. And we note that the majority of consumers who are eligible for regional center services are also eligible for the state's Medi-Cal program. I think it's important to understand that the regional center consumers are receiving services from a broad array of providers. So when you look at issues of access, you need to look beyond just the services that are provided by the regional centers and also look at the services that are provided through Medi-Cal, through school districts, and through other sources. I just want to briefly mention that the Department of Developmental Services operates 3 24-hour facilities known as developmental centers. These facilities provide care and supervision to about 1,030 consumers at this time. And I'm going to talk more about the developmental centers later in terms of how it could potentially create rate pressures. So now if you'll turn to page 3, I'm going to talk about the rate structure in the RC system and how vendors are compensated. So the rates are set in several ways. In some cases, the way the rates are set is determined in statute. DDS sets some rates. They use cost statements or rate schedules. Some rates are established by Medi-Cal. So if a service is provided under Medi-Cal, then the regional centers may pay the provider no more than what is paid by Medi-Cal for the same service. For example, regional centers pay no more than the Medi-Cal rates for dentistry, physical therapy, and registered nurse care. Sometimes the regional centers pay usual and customary rates. So where at least 30% of a business's customers are not regional center consumers or their families, the regional center may pay for their service at the same rate the business regularly charges the general public. Rates are established by the California Department of Social Services for out-of-home respite services that are provided in facilities with in certain facilities. And then some rates are set based on regional center mileage reimbursement. Some rates are set through negotiation between the regional center and the provider. If none of the methods for establishing a rate that I just described apply, then the rate is determined through negotiation between the regional center and the provider. And beginning in July 2008, an upper limit was established for new providers of services with negotiated rates. And this limit was set as the medium of all rates in place at the time for each service. Now, if you'll turn to page 5, I'm going to go over major, over the past decade, the DDS has implemented numerous budget solutions. And here I'm going to focus on the subset of budget solutions affecting regional center operations and regional center vendor rates, generally those that yield more than $10 million general fund in savings annually. So for restrictions on vendor rates, since 2003-2004, several restrictions have been put in place. They generally fall into the following categories: rate freezes, implementations of median rates, which I just mentioned, and also provider payment reductions. So the rate freezes began in 2003-04. Some vendor services, including community-based day programs and in-home respite and supported living services and transportation, experienced rate freezes in 2003-2004. By 2008-2009, all vendors with rates negotiated by the regional centers had experienced rate freezes, with some limited exceptions that you can see listed in the handout. Implementation of median rates began in 2008-09. I already briefly discussed that, so I'm not going to go over that again. I also want to mention that on page 6 of the handout, you'll see provider payment reductions implemented beginning in 2009-10, but there was full funding restored in 2013-14. There's also been reductions to the regional center operations funding. The regional center operations budget experienced a number of reductions between 2003-04 and the current year. For example, in 2009-10, operations budget was reduced by $10.5 million general fund ongoing, and then again in 2011-12 by an additional $14.1 million in general fund. Now, if you'll turn to page 7. The federal government is imposing new regulations on the home and community-based services waiver, which is a source of $1.4 billion in federal funds for the regional center program. I also want to mention that they're imposing these regulations on the 1915I state plan amendment, which also generates an additional $193 million in federal funding. The CMS published the new regulations in 2014. and they're intended to enhance the quality of home and community-based services and provide additional protections to persons receiving these services. And the state of California is embarking on a multi-year process to implement the specific requirements of the regulation. The new rules amend the home and community-based services waiver regulations in several important ways. The rule creates a more outcome-oriented definition of home and community-based settings rather than one based solely on a setting's location or its geography. States will need to evaluate the settings currently in their waivers, and if there are settings that do not meet the regulations, home and community-based settings requirements, work with the federal government to develop a compliance plan. Some programs may need to be redesigned. Many questions arise when you're applying the new federal regulations to our existing programs. And to the extent the home and community-based services programs and services need to be redesigned in order to comply with the new federal regulations, that may drive the need to adjust rates for some of these programs. So it's a potential pressure to adjust our rate schedule. Now, if you'll turn to page 9, another potential pressure to adjust our rates, the governor is proposing closure of the developmental centers. He put forward that proposal as part of the May revision. In response to the governor's proposal, the legislature took several actions, including modification of the administration's proposed trailer bill language to ensure sufficient legislative oversight. The DC closure will require development of new community resources. The legislature approved $46.7 million in general fund for development of these new resources. And the movement of DC consumers into the community will require the development of new community resources. Typically, people moving from developmental centers have very complex needs, and there has to be a team of experts to evaluate their needs and develop a plan before they can be successfully moved into the community. So rate setting will be part of developing new community resources, and they'll need to establish rates that attract vendors who are willing to provide the services necessary for these consumers who have very complex needs. If you'll turn to page 10 now, I want to mention that there's a developmental services task force. The Health and Human Services Secretary has convened this task force. There's one group that's working on vendor rates, and there's another work group that's examining regional center operations. The work group recommendations could inform long-term policy in the areas that we're discussing today. It's anticipated that they may have some recommendations by the end of the year or at the start of the new calendar year, but that's uncertain. But this is potentially a good source of information to guide policy discussions in the future about how we could reform the rate structure for the regional centers. And then I just want to close by pointing out that there have been a number of recent budget actions to increase rates for regional center vendors. The Senate approved $64 million as a targeted increases. The Assembly approved $77 million as part of the budget discussions. The Conference Committee approved a $63 million general fund compromise between the two houses. And then I also wanted to mention that the Lanterman Coalition requested a 10% across the board's rate increase for regional centers, vendors, and also their operations. This would be a total cost for the vendors of $418,268 million general fund, and for the regional center operations, $56 million total funds, $41 million general fund. These estimates were provided by the Department of Developmental Services, an idea of what it would cost to provide that 10% across the board's increase. And that concludes my presentation, and I think we just have one more presentation to go, and then I'll be happy to answer questions.